Good morning, everyone. Thank you for joining us for our Friday morning presentation. My name is Raphael Mlauzi. I'm a registrar in the Division of Otolaryngology at the neck surgery here at the University of Cape Town in South Africa. So today we're discussing a problem that we normally encounter in our ENT practice, which is unilateral vocal cord paralysis. I have no declaration to make, and my presentation is referenced. I used PubMed and Cummings Otolaryngology at the neck surgery, the 5th edition. So unilateral vocal fold paralysis, I will use fold and cord interchangeably. So unilateral vocal cord paralysis is defined as the complete immobility of one vocal fold occurring as a consequence of a recurrent laryngeal nerve injury. So this entity excludes infiltration of the larynx by tumors or fixation of the cricoarytenoid joint from any pathology. There's no definitive epidemiology data in terms of the incidence of unilateral vocal cord paralysis within the general population. The common symptoms these patients present with are dysphonia, which is hoarse voice, and this varies from a mild dysphonia to whispered voice and breathlessness and classical diphlophony, whereby the patient is actually talking but the voice sounds like it's too pitched. Also, they present with a dysphagia and aspiration, about 30% of them. So the aspiration can actually be a cause of a recurrent pneumonias, which can be life-threatening, showing the importance of this condition. Dyspnea is quite rare, and it occurs in about 3% of patients. However, it is important in bilateral vocal cord paralysis, which is not the subject of our discussion today. If we look at the anatomy, this image is taken from the internet. If we look at the anatomy of the recurrent laryngeal nerve, it's a branch of the vagus nerve, and it's got different pathways on the right side and the left side of the neck. If we look on the right side, it branches off the vagus nerve, and then it hooks around the right subclavian artery, whereas the one on the left hooks around the arch of the aorta. So because of the longer course of the recurrent laryngeal nerve on the left side, it is one that is usually prone to injury at surgery because of that long course. So both of them are sent behind the thyroid gland, and then they go in the tracheoesophageal groove to enter the larynx at the posterior at the cricoarytenoid joint to supply all muscles of the larynx except the cricothyroid muscle. In addition to the intrinsic muscles of the larynx that they supply, they also supply sensation below the level of the vocal cord, and also send branches to the esophageal sphincter. In terms of etiology, this varies over geography and time. If one looks at the papers between 1985 and 1995, in large North American series, cancer was the commonest cause, and it was usually cancer of the lung that was causing unilateral vocal cord paralysis. But then, if you look at papers between 1996 and 2005, iatrogenic causes have gone up, and non-thyroid surgery has contributed to most of the injuries, accounting for 66% of the iatrogenic causes. And this is because the authors attribute this to using monitoring of the recurrent laryngeal nerve intraoperatively that has brought down the causes of recurrent laryngeal nerve injury to thyroid surgery at 33%. And also this shows that there's been a lot of surgery that has been going on in terms of causing this injury. So in one paper that looked at 938 causes of unilateral vocal cord paralysis, this paper was published in 2014. Surgical causes occurred in 55% of the total cases of cord paralysis, and thyroid and parathyroid surgery accounted for 16.8%, and non-thyroid surgery 38.8%. Other causes include echinoplastic causes, idiopathic, the traumatic, intubation, and finally radiation, CVA at 1.9%, and also neck radiation at about 1%. In terms of the diagnosis and workup of these patients, we first need to take a history and do a full ENT examination. Flexible laryngoscope is the gold standard for the diagnosis to assess the vocal cord movement, which can either be cadaveric or it can be paramedian, depending on the level of the injury. Because we know that the injury doesn't mean transection altogether. It can be a neuropraxia and it can be anything in between. This can be combined with a video stroboscope if it's available. And this helps with assessing glottic closure, especially posterior glottic closure and the mucosal wave pattern. Electromyography, where it's available, can be used to assess denervation or reinnervation potentials. In terms of imaging, a chest X-ray will be useful if you suspect any lung pathology, if you suspect lung cancer, or you suspect TB, especially in the upper lobes. CT scan, we normally order CT scan of the neck and upper mediastinum to find out if there are any tumors there. Ultrasound scan can be used. It's got high sensitivity in the neck and thyroid regions. And MRI, which we rarely do here, is superior to CT scan at the skull base. So in terms of management of these patients, we need an accurate diagnosis, and we also need prognostic information on these patients. How well are they going to do? And we also have to take into account the needs and the lifestyle of the patients and what the goal of treatment is. And there's variable recurrent laryngeal nerve restoration in about 6 to 12 months without any intervention. So there is room for observing these patients depending on how severe their symptoms are. There is room for voice therapy and there is room for injection laryngoplasty, which I'm going to discuss shortly. Factors which influence the choice of treatment depend on the patient's age, their comorbidities, are they good general anesthetic patients, the patient's expectation and what they expect their profession is, do they use the voice a lot, and the treatment facility one is at, and the clinician's knowledge and competence, and also the availability of equipment at the institute where one is working. So literature talks of these 4 pillars of treatment of recurrent laryngeal nerve injuries. The first one is injection laryngoplasty. The second is medialization thyroplasty, also referred to as type 1 thyroplasty, arytenoid adduction, and laryngeal reinnervation. I'll go into details through each one of these. But the whole aim of this treatment is to medialization of the paralytic vocal cord to restore the correct coping of the vocal cords during phonation and rehabilitating the swallowing sphincter. The first one is injection laryngoplasty. There are two, the substances that are used for this can be divided into 2. Temporary ones and permanent or long-term. The temporary ones include carboxymethyl cellulose, also known as prolarin, and this is what we use a lot here at British Care. Also available on the market is bovine gelatin, also known as gel form or certiform, and collagen-based products like Symetra, and also hyaluronic acid, hyaluronic. Permanent or long-term substances that can be used include autologous fat, calcium hydroxyapatite, polydimethyl siloxane, PDMS or particulate silicone, and polytef paste, also known as Teflon. However, this is discouraged. It used to be used quite a lot when these procedures were first started in the 70s, but then they discovered that the more they used the polytef paste, Teflon, they tended to be granulation tissue and reaction from the vocal cord. Some patients had to be taken back to theater to actually excise these granulation tissues that were forming. So it is actually discouraged. So in terms of the technique, injection laryngoplasty can be done in 3 ways. One can do a percutaneous injection or a transoral injection or a laryngoscopic injection under GA. The first 2 can be done in the office, as we shall see shortly. On the lateral percutaneous approach, which by the way can be done also from the anterior, but I just mentioned the lateral percutaneous approach. This is done through the thyroid ala midway between the thyroid notch and inferior border of the thyroid ala laterally. And this needs direct visualization of the nickel with a flexible scope. That means you actually need 2 people. One can do the flexible scope, and then the other one can hold the nickel, all connected to a screen. And then using under direct visualization, one injects the whatever material they are using just anterior and lateral to the vocal process, and on a plane which is level with the lower border of the middle edge. The second type of injection laryngoplasty is transoral injection. This can be done in the clinic. 4% lidocaine is applied to the laryngeal and pharyngeal mucosa to numb and to try to prevent the gag reflex. The patient can hold the tongue forward, and under indirect visualization, injection is done with a curved laryngeal needle. For those patients who are anxious, who cannot tolerate a flexible scope, this can be done under general anesthesia, and the target is the paraglottic space. So the needle is inserted anterior and lateral to the vocal process, about 2 millimeters deep or at a plane level with the lower margin of the true vocal cord. The advantages of injection laryngoplasty is that it is quick and it can be done in the office, at least the percutaneous and the transoral injection, and also the ease of performance if you've got the skill. The disadvantage of this is that it's a temporary effect, and some patients actually need repeated injections over time. Some of the disadvantages which you rarely see here are stiff vocal cords, dysphonia, airway obstruction, vocal fold, erythema, and pain. There's a chance that you can actually under-inject or over-inject. And there's also migration of particles and the granuloma formation. This occurs in Teflon, as I've said. The second surgical procedure that is done for unilateral vocal cord paralysis is medialization thyroplasty, also referred as type 1 thyroplasty. This is augmentation by placing an implant into the vocal cord. Such implants include silastic or dense hydroxyapatite or Volcom. This can be combined with Arytenoid adduction, which I'll discuss next, or reinnervation procedures. This can actually be done under local anesthesia. So in creating the thyroplasty window, one makes a 6 millimeter vertical by 10 millimeter horizontal window, and it has to be 5 to 8 millimeter posterior to the anterior midline in females, and 8 to 8 backwards in males because of the wider angle of the thyroid cartilage, 8 to 10 millimeters in males. And the superior aspect has to be at the level of the true vocal cord. What is important is that the inner perichondrium must be preserved. It should never be breached. So this is a diagram showing an implant that has been placed to try to correct, to medialize the vocal cord. So the advantages of this procedure is that one uses local anesthesia, and it's quite dramatic. I've seen one of these operations. It's quite dramatic how it occurs. The patient is hoarse, you take them to theater, and then as you place it, you ask them to talk, and there's immediate voice improvement, quite dramatic. So you can actually do voice assessment during the procedure, and it is potentially replaceable by actually removing the silastic. And there's also a preservation of the vocal fold integrity. You don't interfere with the vocal cord. However, the disadvantage of this procedure is that there could be implant migration or extrusion, and it is an open procedure, and so it is prone to infections, and there's limited posterior glottic closure, and there's a chance that you can actually have the airway obstruction if the implement actually dislocates. The third arm of surgical treatment is Arytenoid adduction, and this mimics the action of the lateral cricoarytenoid muscle by closing. It closes the glottis by arytenoid rotation, and it is usually performed in combination with the medialization thyroplasty and the injection laryngoplasty. And this can be done under local anesthesia, or if the patient is anxious, one can do this under general anesthesia. So in terms of the technique, it's an adduction suture that is placed in the muscular process of the arytenoid, which is actually the origin of the lateral cricoarytenoid muscle. And then this suture is passed forward through the paraglottic space and is secured to the inferior alar, as we see in the next diagram here. So that arrow shows the suture being placed in the muscular process and then being carried forward to be sutured in the thyroid alar at the base. And this also is the same diagram showing the same. In terms of advantages of this procedure, there is better closure of the posterior glottis, and it addresses the level of the vocal cords, and it increases apparent length of the paralyzed vocal cord. However, the disadvantages are that it is more invasive, and as can be seen from the diagrams, it looks like it's technically difficult. It's not well trained. There's also a risk of airway obstruction, a joint dislocation, the cricoarytenoid joint, there's a risk of a fistula formation and a risk of carotid injury because you are operating quite close to the carotid artery there. And it is less effective in long-standing unilateral vocal cord paralysis. The fourth arm of surgical intervention is the laryngeal reinnervation. And there are three arms to this. The first one is the Ansa cervicalis recurrent laryngeal nerve anastomosis. Instead of the Ansa cervicalis, one can actually use the hypoglossal nerve as well. The next two, which is the neuromuscular pedicle, which is the placement of the Ansa cervicalis branch to the omohyoid and taking a small muscle block onto the denervated laryngeal muscle. This is not so well described in literature, but the people who actually started this procedure are actually seeing very good results. The third one, also the direct nerve implantation of into denervated muscle, has also been described, but it's not much used. I didn't see much articles of it in literature. These laryngeal reinnervation techniques actually improve muscle tone, mass, and bulk. However, there is no improvement in movement, and it has been found to be quite good for children, and it can be combined with medialization thyroplasty. So laryngeal reinnervation techniques can either be non-selective or selective. Selective won't go into because it's done for bilateral vocal cord palsy, but the non-selective ones, it's the anastomosing of the recurrent laryngeal nerve to an adjacent motor nerve or to the recurrent laryngeal nerve itself. This reinnervates both abductor and adductor muscles, all the intrinsic muscles of the larynx without any discrimination. So that's why it is actually called a non-selective. So the injured recurrent laryngeal nerve is anastomosed to the adjacent motor nerve, typically the Ansa cervicalis or the recurrent laryngeal nerve itself, as I've said. This non-selective reinnervation reinnervates both the intrinsic and the adductor muscles, and this usually results in synkinesis, and it prohibits the normal mobility of the vocal cord. However, even if there is prohibition of the normal vocal cord mobility, there is a decreased natural muscle atrophy because of that tonic signal to the reinnervated muscle. And it results in optimum positioning of the reinnervated vocal cord, including posterior glottic closure, proper height and rotation of the arytenoid, and symmetric thorough arytenoid stiffness. The advantages of the Ansa cervicalis recurrent laryngeal nerve anastomosis are that, as I've said, it provides tone, position, and bulk, and there's less asymmetry in the vocal cords, and it makes for good rehabilitation of the unilateral vocal cord palsy, and it can potentially be reversed. And stem thyroid sacrifice may theoretically improve vocal function because it has been found that the sternothyroid muscle actually causes a lateralization of the vocal cord during quiet respiration. So theoretically, if you sacrifice it, it's bound to improve vocal cord function. But in terms of clinical aspects of it, the evidence of it, in terms of patients, it's very scant. And it's also one of the advantages is that it ends up with a near-normal voice quality. However, the disadvantages are that it's quite a long procedure due to the deeper dissection that is needed. And the patient has to undergo general anesthesia. And once you do it, it eliminates the possibility of a spontaneous vocal fold recovery. So you've actually taken ownership of the recurrent laryngeal nerve by doing this procedure. And that the results actually take some time for you to see them in terms of the improvement of the voice quality, actually taking about 5 to 9 months delay for these results. And that's why there's an advocacy to wait for at least a year before doing this procedure. So this means that you actually have to do it in patients who are not aspirating or getting recurrent pneumonias. Otherwise, you can't wait for a year to do this procedure. And it needs an intact Ansa cervicalis and distal recurrent laryngeal nerve stem. And the disadvantage also is that the consequences of operating on the wrong side are severe. Like if you go to theater, instead of operating on the right side, then you go on the left side. Then you've got bilateral vocal cord paralysis in front of you. So you've actually escalated the pathology and you have to deal with it. So it's important to actually make sure that you're actually operating on the correct side. And in terms of voice outcomes of laryngeal innervation, the largest series that we saw was the 200, that is actually published, is 237 patients who had the vocal cord palsy post thyroid surgery. This underwent Ansa cervicalis, recurrent laryngeal nerve anastomosis, and according to the investigators here, there was near normal phonatory function in most reports. So in terms of which is better, which of these four methods is better than the other? A systematic review of the literature evaluated these four methods using PubMed database from 1998 to 2014. And the conclusion was that there's no significant differences between treatment arms based on perceptual acoustic quality of life and laryngoscopic outcomes. So when do you do injection laryngoplasty? There's this study where they looked at 66 patients who had injection laryngoplasty with gel form collagen, RLN, or a combination of those. The investigators looked at, divided these patients into those who had immediate injection, immediately defined it as within 3 months from the time of injury. So a patient gets operated, and within 3 months, he was injected with any one of those gel form collagen, RLN, or a combination of those. And then those who were done early were done within 3 to 6 months of the injury, and those who were done late were done after 6 months of the injury. So their conclusion was that there's a statistical difference between those who are done late and those who are done in the early or immediate group, as can be seen there. So in terms of those who went on to need thyroplasty, 1 out of the 21 who presented in the immediate group actually needed a thyroplasty, and 2 out of the 17 in the early group, those who were done between 3 and 6 months, went on to need type 1 thyroplasty. And those who were done in the late group, 20 out of 28 of them, went on to need a thyroplasty further procedures. However, the critique of this study is that it is possible that we know that there is actually a recovery of the recurrent laryngeal nerve without any intervention. So it could be possible that out of those 21 who were actually in the immediate group, there were some who were going to recover anyway. And then maybe in those who came late in the more than 6 months group, like maybe they came at 9 months after the injury, it is possible that that cohort actually included patients who were never going to recover anyway, whatever you did, you were going to need medialization thyroplasty. So this is the critique of this study. However, there is general support in the literature that doing the injection laryngoplasty immediately actually tends to benefit patients. So if you have all the skills, then the decision is, if a patient presents to you with unilateral vocal cord palsy, what procedure are you going to do? Are you going to do injection laryngoplasty? What we look at the patient characteristics, the comorbidities, in terms of the patient expectations. Are they getting aspiration? Are they doing, so which one are you going to choose? So as a general guideline, if a patient comes with mild or moderate dysphonia, then you can counsel them and offer them speech therapy. If there is confirmed denervation, for example, on the electromyography with aspiration and severe dysphonia, then these patients will require early medialization thyroplasty. If there's early recovery, either visually on the flexible scope or on the electromyography, then injection laryngoplasty will certainly do no harm. And if there's poor prognosis for vocal fold recovery, early medialization thyroplasty can be offered to these patients. If there's a short life expectancy with aspiration or severe dysphonia, percutaneous medialization in the office can be offered to the patient. And if the patient can wait for improvement of the vocal fold function without any severe symptoms, then laryngeal reinnervation can be offered to them. And in patients requiring above average vocal quality, a reinnervation procedure can be done. Thank you very much. I'm going to invite any questions and comments.
Thank you, Raphael. I think that was really, really excellent overview. I think very important issue always is foreign thyroid surgery, speak to the thyroid surgeon and find out whether they've actually divided the nerve or whether the nerve is intact. And the difficult group is always where the thyroid surgeon doesn't know whether the nerve is intact or not. Because there you have to really speak to your patient, and it's going to be up to the patient how important their voice is. Because if you have a teacher who can't teach, or someone depending on their voice, then you might end up intervening earlier than someone who can wait 6 months to a year for spontaneous recovery should the nerve intact. Do you agree with that? What's your opinion?
Yes, I think so. The patients profession is very important in terms of pathology.
Yeah.
I'm not sure if this monitoring of the recurrent laryngeal nerve is actually of benefit to these patients, because they seem to actually applaud it as one of the ways in which they've managed to bring down the nerve injuries because of paralysis.
And then the other benefit would be by the patients who have a high vagal palsy. But when you resect the nervous vertebrae or a schwanner from the vagus nerve, you affect the superior laryngeal nerve and the recurrent laryngeal nerve. And then it's cervicalis, because I think you aspirate far more than what's part of the journey. Do you want to ask Rod then to comment? Ross, do you want to comment?
Ross, can you help us? Unmuting. We want to unmute Ross.
Should be able to.
So we've been trying to do a lot of them under local, because a lot of them are cancer patients and we don't have this and they're not fit for general anesthetic. The problem we have is so we anesthetize them well. We give them lidocaine inhalations an hour before, every 15 minutes we spray. And it's not an easy procedure for them to tolerate. The problem we have with the prolarin needle, the percutaneous one, it's too thin, so it doesn't penetrate through cartilage. So you kind of have to go from the bottom and get that angle right, and it's very difficult to get it anterior. So because the needle is just too soft. So the problem with the needle that we have without prolarin, it's not easy to do in the clinic, because you can't penetrate the cartilage. So we've got to do it through the mouth transorally, and you anesthetize what you can. At the moment it touches that mucosa, they do gag. So you need a very cooperative patient, and it's quite horrific for them to see this needle there. So we try it because it's their only chance, and they've got cancer. They're not going to be sent for theatre, just to give them a voice back, but it's not an easy procedure. I think the other thing is we often get called in stroke patients to say they want to, the speech therapists might call us, or the doctors to say they want to medialize it because they aspirate. But I think the problem there is often it's a sensation. It's not just a cord that is not moving. So even if you medialize the cord, they're still going to aspirate because it's a sensation problem. I think that's what you were talking about, the high. So I think it's very important you must work together with your speech therapist to make sure it's not a sensation thing, because they no matter what we do, they're still going to aspirate. And I think sometimes when you stroke them, you just need to look. Those very lateral ones, those are often a long-term ones. You can inject what you want, they don't do well. You need to do a thyroplasty. We don't have the procedures here at Hoodski, so I just cut synaptic blocks, and it works quite well. There's nice videos on YouTube on how to cut them. You must just get the size right. And I must say, I don't often do them under conscious sedation and local, just because often somebody's been in the neck before, and I'm still junior. So it's very tricky to, if somebody's been in me before, to do it under local. I'm not comfortable with that. So I unfortunately do give them general anesthetic, because it's sometimes tricky for me, probably not for the other surgeon, to get them synaptic in, because you kind of have to push sometimes. So I, in my junior capacity, still do general anesthetic for them, because if somebody has been in the neck before and there's fibrosis, I find it tricky. It's more stress for me under conscious sedation to go and put a prosthesis in there, if somebody's in there before.
And if you do it with a flexible scope in place, you can see how much you utilize the board on the GA.
Not often.
Yeah, because that's something you can do.
Yes.
They want to overclose.
Yeah.
Have you got experience?
Yeah, we are doing it very presently. For early cases, always temporary injections. But all that patients, if the vocal cord paralysis gets first speech therapy in Turkey, at least in our department. And then after that, we also, it's so expensive, all that injection materials, things like that, in our country, I would say. So we do frequently thyroplasties. For thyroplasties, we are doing always under sedation. So because we can check the also voice quality and also, like we say, flex laryngoscope, how much we push it. And we are using either silicone blocks or vortex, so vascular grafts, things like that. I think both of them work, so it depends on the surgeon's choice. What we are basically doing is, first we are giving sedation. They're just completely sleeping, I would say. And then we're just opening the small neck, and we are just removing the window from cartilage and putting the graft. And then we are asking the anesthetic team to make the patient elevate. So we are putting the flexible scopes and ask the patient to talk. So we can assess the voice and we can see the opening of the cords, or closing of the cords, airway. And that's how we do it.
There's a question, if you can help me on this one. You're saying the patient with bilateral vocal cord paralysis, would you advise to operate both cords as a one-stage operation?
To reanimate.
Yeah. Well, it just says to operate on both cords as a one-stage operation.
I would probably not push it the word airway, so you wouldn't do a thyroplasty because you would have an airway problem. I've never done the reanimation. We had one patient that was bilateral, and by the time we got on the list, she did recover. But I think what is important, the reason why they do it with kids is it takes a while to recover, and you never get movement back. You might get tone back. So bilateral ones are still tricky to do. But you would probably reanimate it, but you would probably do one at a time, I would think. But you've just got to remember, if you are going to try the reanimation, you've just got to do a temporary thyroplasty at the same time. So you kind of bind in time until they start moving slightly. So it's not just a reanimation, you've got to do a G4 at the same time. James, do you have a question? You can speak.
James, you can go ahead.
Hello, can you hear me?
Hello, James, we can't hear you.
Yes, okay. Just first, hello to Dr. Fagan. And just if you could mention some
You're
of
talking, but we can't hear you.
Can you hear me now? 1, 2, 3, 1, 2, 3.
Yeah, we can hear you now.
Okay, first, hello to Dr. Fagan. Just if you could mention a few of the non-thyroid surgery that caused unilateral vocal cord paralysis. And then a comment, Dr. Peek Wu of New York City, who is an expert in this procedure, found that after medialization, he had to do adduction of the vocal cord with the muscular process. And then just the comment, I could hear your speaker very well, but your peripheral speakers, maybe you could get a microphone that you could pass around. It would enable some of your people to hear their comments, because I was unable to hear their questions and comments. Thank you.
Thank you so much, James. Yes, I do agree about the medialization thyroplasty, that indeed after you medialize, you still have that posterior glottic gap, and therefore augmentation with the adduction procedure, Arytenoid adduction, does make a lot of sense. Thank you so much. We'll look into that about the microphone. Any other questions or comments?
But very much like Rose, if she can come on for another speech therapist to comment about the role of speech therapy.
Rose, if you may please unmute yourself. We would like to hear from you.
want to talk to us.
So we have, there's 3 nurses that we've seen in the voice clinic that after COVID has severe dysphonia, that they literally can't talk. Normal vocal cords, but it's as if the COVID probably triggered like a hypersensitive larynx, and now they learn to talk the wrong way and they use all the muscles and we just can't get voice. So I'm actually I'm gonna get them bigger phones. So I'm sorry about the copy hack, like saying my nurse can't talk.
Raphael, thank you very much for the excellent overview.
Thank you so much for attending. We'll meet you next Friday again for our presentation. Have a good day.